Hello, everyone. My name is Dr. Wei On. I'm from the Leeds Teaching Hospitals NHS Trust, United Kingdom. And I'm pleased to be here to talk about our study titled EUS-guided choledochoduodenostomy with electrocautery-enhanced lumen-apposing metal stents in patients with malignant distal biliary obstruction, which is a multi-center collaboration from 8 institutions across the United Kingdom and Ireland. I would like to preface this talk by once again thanking the editorial board of GIE for publishing our study, and also to all the co-authors who collaborated with us. The recent advent of electrocautery-enhanced lumen-apposing metal stents, which I will now refer to onwards as LAMS, has simplified the procedure of an EUS-guided choledochoduodenostomy in providing biliary decompression for patients with malignant distal biliary obstruction. There has been increasing amount of studies being published demonstrating the utility and efficacy of these stents in this particular cohort of patients. In our retrospective study, which analyzed the outcomes of all consecutive 120 patients who underwent the procedure, we demonstrated a technical success of 90.8%, a clinical success of 94.8%, an adverse event rate of 17.5%, with a biliary reintervention rate of 8.3% over a median follow-up period of 70 days. These results are comparable with data from studies published from other centers. There were some aspects of our study which reflects the relative novelty of the procedure and the device, which we felt appropriate to share with the international endoscopy community. Firstly, we included data and a narrative on the circumstances behind the reasons for technical failure in our cohort. We described how incidences of stent misplacements or dislodgements were salvaged. We demonstrated that successful salvage can be achieved by placement of a fully covered metal stent through the LAMS, leading to no ill clinical consequence and also concurrently providing biliary drainage. In particular, we shared our experience of preloading the stent delivery system with a guide wire to secure biliary abscess before deployment of the second flange of the stent. This practice permitted bridging of a multiploid stent with a fully covered metal stent if necessary. Secondly, we shared our data on the key outcomes from the use of LAMS with different diameters. The 3 diameters of stents used in our cohort were the 6mm, 8mm, and 10mm stents. As there were only 5 patients in our cohort who had the 10mm stent, we grouped these 5 with those who had the 8mm stents, thereby producing the following ratio: 46 patients who had a 6mm stent and 73 patients who had an 8 or 10mm stent. We demonstrated no differences in technical success of the procedure between the 2 cohorts. However, the adverse event rate was higher in those who had a 6mm stent with an odds ratio of 3.71. This observation was not due to an increase in peri-procedural adverse events, but rather due to higher post-procedural cholangitis and reintervention rates. It is plausible that the smaller lumen of the stent accounted for these observations. Thirdly, we also shared our experience of the practice of routine double stenting, which is the placement of a double pigtail biliary stent through the lumen of the LAMS to augment biliary drainage and to anchor the stent to prevent migration, and this practice had been described by other centers. This practice was performed in 32 of our patients. Crucially, we demonstrated that when double stenting was performed, there were no differences in adverse events, cholangitis, or reintervention rates irrespective of the diameter of the LAMS use. On the contrary, where double stenting was not performed, the use of 6mm stents was associated with increased adverse events in the post-procedural period, reintervention, and cholangitis. Fourthly, we performed an analysis of potential predictive factors of technical success and adverse events. Endoscopic expertise was evaluated, being predefined as having had 10 years of prior EUS and ERCP experience, and separately proficiency in LAMS placement, which was predefined as having performed 40 LAMS placements for drainage of pancreatic fluid collections. We demonstrated that endoscopic expertise, amongst other factors such as size of the bile duct and method of bile duct puncture, were not predictors of technical success or adverse events, And the only variable associated with increased adverse events was the use of a 6mm diameter stent for the reasons explained before. To summarize these points, it appears that using a smaller diameter stent may lead to increased risk of cholangitis and reintervention, although this may have to be balanced with the slight increase in technical difficulty in deploying a larger diameter stent, especially in a smaller size bile duct, which is noted in our studies, although not demonstrated in ours. However, the practice of double stenting appears to mitigate any differences in outcomes irrespective of stent size. Furthermore, endoscopic expertise based on our predefined thresholds did not appear to be predictive of technical success or adverse events. These pointers should drive an impetus for further prospective research into topics such as the choice of stent and the diameter chosen, the practice of routine double stenting, which could potentially be a low-cost, high-reward practice, and formal evaluation of the learning curve associated with this procedure. Lastly, the increasing usage of EUS-guided biliary drainage may start to challenge the dogma of ERCP being first line for biliary decompression in these patients. The advantages of EUS-guided biliary drainage in this setting would be the ability to perform tissue acquisition at the same time. It would be possible to perform in situations where ERCP would not be possible, such as where there is tumor infiltration precluding passage of the duodenoscope to the papilla. It would circumvent any potential difficulties in selective biliary cannulation. Post-procedural pancreatitis may be negligible as there's no instrumentation in the vicinity of the papilla, but of course this remains a risk if a FNA or FNB is performed. EUS-guided choledochoduodenostomy may also be feasibly performed in patients of surgical candidacy, and in our study, we identified 9 patients who had EUS-guided biliary drainage, who subsequently underwent surgical resection of their primary tumors. This was also demonstrated in other studies. Further prospective studies are certainly required to evaluate EUS choledochoduodenostomy to define its place in the algorithm of treatment of these patients. Potential questions include its role as primary modality of drainage, as a salvage procedure following unsuccessful ERCP, and its role in patients with both operable and non-operable disease. Thank you very much for your attention.